Hello, this is Frederick of the Collaborative Care Collective, and I'm here with physician and founder of the Collaborative Care Collective, Dr. Tim Mazzola of Breakthrough Regenerative Orthopedics. Welcome, Tim.
Thank you so much, Chris. It's great to be here.
Yeah, I'm so excited that you are here because we have a summit coming up, and I'd just like to inform the listeners of exactly what it is that the Collaborative Care Collective Association is and what are we doing? And so I guess we'll start with that. Can you explain to us what is, can we call it C3 for short?
Absolutely.
Okay. Yeah, what
So,
it is and why you started it.
well, C3 or the Collaborative Care Collective is really, it was, I would say, a calling for me. And I know that sounds maybe heavier than it needs to, but it's the truth. And what I mean by that is that there was one patient in particular that motivated me to learn a lot more about the case of sacroiliac instability, and I learned how to diagnose that from a physical therapist colleague of mine here in town named Don Sandalchidi, who you know, Chris. And this client happened to be another physical therapist in town, and her story was a sad one, and had been out of work for like 6 years. And so the recognition that an excellent physical therapist working in my town could be out of work for 6 years because of a rather simple case, in my opinion, of sacroiliac ligamentous laxity from birth and some hypermobility was enough to put her out of work for 6 years. And she had sought excellent healthcare providers from the traditional healthcare systems. To me, it was a shocker. It was saddening, and it left me with a longing for our healthcare system to be better at handling those kinds of patients. So that's really where it all started, Chris, was with a patient that was really a sad story, frustrating, and one of our own, a PT, which is your profession as well. And me being a physician, trying to manage her care, she was sent to me by another physical therapist. And I recognized that we needed to get this out there. I needed to find a platform by which to better educate other providers in the physical medicine space about how to work with more complex patients and work in collaboration with others to affect the best possible outcomes. And so it occurred to me that because I had some unique experiences, both with collaborating with PTs and other healthcare workers in my area, as well as some special training and learning in this area of SI instability, that perhaps I needed to teach it and teach both of those things. And so it took about 2 years for me to get over the initial realization that this needed to happen before I was actually willing to take on the workload associated with it, because I was new in my own clinic and still was developing my own clinic. And there's a lot to that, running your own business. So it took me a little while to get there, but then I found a great team of providers who was willing to join me in that endeavor. It started with Dawn and with Gail Wetzler, and they quickly brought in Diane Lee. Of course, I wanted my physician colleagues, Phil Steele and Brad Fullerton. And all these are just really great people and great providers. And then I know that you got brought in through Brad, right? And so it was kind of this constellation. C3 is a constellation of like-minded providers who really want to look more deeply into these areas of the more complexity. When simple patients are simple, we get those better easily. But then there's these more difficult ones that are really suffering. And I think the big idea behind C3 is that we need to learn how to think better, understand anatomy better, as well as how to make diagnoses more accurately. And then the second piece, which is equally important, is learn how to work as a team, as collaborators, because none of us has all of the answers. So even if I knew everything I could know as a physician about that patient and many others since then, I couldn't get them better on my own. So we needed people like Dawn and Gail and yourself to come alongside of them and then help them in their journey. So
I
that
thought
was the reason for that's where the collaborative piece comes in.
it's wonderful and it's very exciting to talk about this. Let's talk about SI joint laxity. And before you got your special training and your knowledge about how to treat that, you must have had sort of the standard of care, if you can call it that, if it was even care,
Hmm.
um, that others, that the way your mentors or your schooling addressed that particular diagnosis and how your collaboration with others got you to another level of success with this particular diagnosis. Can we dig down a little deep into this topic? Because it's so common, this diagnosis, and a lot of people are suffering out there. And this is just right on to the story, really about the story of why you created C3 and your training and how it's different. Uh, if you would mind telling us that story.
Absolutely. I mean, it's been a long journey, Chris, and you're right. I started my fellowship in sports medicine, so I'm a family physician by training, who then did sports medicine fellowship 2003 to 2004 here in Colorado at the University of Colorado. Great mentors, great physician colleagues. I had not only orthopedic surgeon colleagues and trainers, but I had family medicine because that's my primary field, mentors, as well as physical medicine and rehab, so PM&R. And everyone has a little different angle on things. So just to differentiate the different specialties, orthopedic surgeons are rather obvious. They're doing more of the steroid injections and the surgeries. The physical medicine and rehab docs tend to be more spine and musculoskeletal, but also a lot of neurologic and rehab from neurologic injury, such as spinal cord injury and brain injury. But they have excellent orthopedic anatomy and understanding, but they don't do surgery, right? So it's more of a kind of supportive, rehabilitative role. But many in the PM&R field have stepped into this regenerative orthopedics space, non-operative. And then myself as a family medicine, sports medicine, my training was more of the holistic whole patient, and then sports medicine on top of that. And again, influenced by all the different realms, including osteopathy. So DOs, work with physical medicine and aligning of the joints and the spine and the SI. So I had a lot of different influences. And one of the family physician mentor who I had in my sports medicine training was a DO. And so he gave me my first insight into SI joint dysfunction, ilial rotations around the sacrum that's twisted with a lumbar rotation that occurs. And many osteopaths, chiropractors, and PTs are really excellent in this field. And I never have been really excellent in that. But I got an understanding, and it made me very curious. How is it that he's seeing these SI joint dysfunctions and believing that he can correct them? And I see that their bones are all aligned when they're after, and the patient feels better. And then I had a physical medicine and rehab mentor who was telling me that the SI joint doesn't and cannot move because the ligament structure is so robust, and it's been proven that there is no movement, there is no laxity, and so that it's foolhardy to involve yourself in endeavors that relate to that kind of notion. And so I was left with that because I had two mentors who I both looked up to who left me with this problem. And my brain doesn't like unsolved problems. And so I just stayed with it over a 10, 15, 20-year period. And then, I was, the usual standard of care would be to do diagnostic injections into the SI joint if you think that that's the source of somebody's low back or posterior hip pain, and then see how they do. And if it takes away their pain, then you presume that, yes, it's the joint that's causing the pain, maybe do a steroid shot. If that doesn't work long enough or last well enough, then they do denervation kinds of procedures where they're actually ablating nerves to the joint. But then along the way, I've been teaching ultrasound, like how to do orthopedic ultrasound and non-surgical orthopedics with the use of an ultrasound guidance for many years, and teaching with some of the best physicians in that realm across the country. And they were using regenerative treatments for the SI ligaments that they were saying relax. They were osteopaths. They were using regenerative medicine. They were using ultrasound. And then they informed me of a study that was done by Dr. Murakami in 2009, where he distinguished between a diagnostic injection of the SI joint and of the SI ligament just outside the joint. And effectively in his study, he showed that everyone got pain relief when you injected the ligament that was suspected to have SI joint dysfunction. and only 9 out of the 25 got relief with joint injection and joint numbing. And so the 16 patients in the 25 that didn't get relief with injection into the joint, he backed out into the ligaments, and all 16 suddenly had pain relief. So that really changed my thinking about SI joint versus SI ligament. And then I was lucky enough to meet Dawn Sandel-Cheedy, who came into my clinic one day, and she had been trained by Diane Lee, who I know is a mentor of yours as well, who's one of the most well-respected PTs in the world, maybe one of the smartest people I know. And Dawn had learned how to assess for sacroiliac ligament laxity through a physical exam technique that Diane had taught her. And then Dawn taught it to me and said, you can know if it's loose or not, just simply, it's a simple test. And she showed it to me and I learned how to do it. And I wasn't as good, obviously, in the beginning, but I've gotten better over time. So it's not one person really that influenced this development, right? I had my initial problem of my mentors not leaving me with something unsettled, that one saying that it did move, another saying it didn't. And then we had this traditional care that's the joint, and then Murakami saying it's really probably more the ligament. And then a number of people that I taught with that kind of influenced me to think about it differently and to think about regenerative treatments. Then Dr. Saunders, Saunders, out of Australia, published a very nice research study that compared doing prolotherapy, sugar-based dextrose injections into the SI ligament versus PRP into the ligament, platelet-rich plasma using your own blood cells. And she was able to demonstrate over a year out from the injections that the platelet-rich plasma led to better outcomes even than the prolo, even with using half as many injections. So then that kind of stimulated some thinking like, so there's some things that are better than others that have long durable effects. And then now I have a physical exam technique to be able to determine if people have this thing. It's not just a constellation of tests where you kind of wonder if maybe they have it and then base it on diagnostic injections. It's an objective physical exam knowable thing. And I started treating people's ligaments with PRP, and lo and behold, their ligamentous laxity was going away. So the objective test that Diane Lee had taught us, the ultrasound guided PRP that Dr. Saunders had taught us, Dr. Murakami, you see what I mean? It's like we're standing on the shoulders of giants. So even though I have some special learning, it's really more like I just took everybody else's and constellated it into a new way of doing things for me and my patients. And then using the team around, like Dawn was excellent at doing rehabilitative exercise and helping people to get their multifidus muscle to turn on. It was always shut off after we'd treat their SI ligaments, get their glutes to work again, and just to slowly but surely bring them back. And this could be after 5, 10, 15, 20 years of dysfunction and pain. So it was what really inspired me, I think, yes, my patient Kristen was the one that kind of tipped me over into realizing I needed to make this more known. But I'd had so many other patients like her whose lives were completely altered by this condition, and they were getting their lives back. And I think that for me was the revelation. It's like, okay, this isn't just a neat thing to know medically. This is actually changing people's lives and is transformative. And therefore, it needs to be better understood with the hope that we can change the standard of care for this kind of condition.
That's wonderful. It sounds, well, in a nutshell, then the philosophy of your practice as it pertains to a team, how would you, in a nutshell, put it together for us to visualize who does a patient see first? How does it work with referral? Oftentimes people will see a physical therapist because they got a prescription, or though these days they can walk in off the street with the independent practitioners of physical therapists these days.
Right.
And then now let's talk about the physical therapist. They get a patient and they hit a plateau. There's different routes, and usually we have to say, go get imaging. It's possible that you need more reports, more an MRI, an X-ray, an ultrasound, et cetera. And they would just send it to, I guess, the physician that they work with, or not, just help them just to find someone who does this kind of work. And then there's exercise, right? The allied healthcare professional. A lot of people are doing Pilates and strength training and other things. And they all intersect, right? At some point, they all intersect.
That's
So
right.
what is that the ideal team and what should they be doing in terms of, I think, talking to each other, communicating, not waiting too long, right? Could you, tease that out for us?
Yeah, I think that's a great question about how does the team operate and what's the way it usually works or ideally works. And yeah, I mean, there's so many different ways in which it will work just depending on who the patient is seeing first, right? But in general, I always encourage my patients who have orthopedic concerns to have a trusted physical therapist on their team. If they're really active and they want to stay active, then it's not uncommon. I'll recommend that they have a personal trainer on their team. And sometimes they can find those two people in the same place. Some PT outfits have that whole gamut of care, and that's amazing. Um, some of the PTs have Pilates, right, and have movement therapies and courses. Some are body. Some of the people that come to our course are body workers, and they're doing, say, myofascial release, or they're doing visceral therapies. Um, so it really can happen in any order. But I think the big idea that what I'm hoping for that comes out of C3 is that people that come to our course come not only alone, but with their trusted colleagues from within their communities. And if they don't have them yet, then to come and be encouraged by seeing others that do and how well it works for their patients, who then can be kept at the center of the care team. So this is patient-centered care at its finest. And the way I like to see these teams work is like certainly a physical therapist who's trained in thinking through complex problems well, and then um, maybe a personal trainer or a movement therapist or a Pilates trainer, someone like that on the team. Um, and then if they are tight and have a need to release trauma from their body, having a body worker, maybe a Rolf, maybe a Feldenkrais person, maybe a Frederick stretch therapy trained person, um, or I think I did say myofascial release, right? So those are kind of all the ones. And then we have the physician side. So for the non-surgical orthopedics, then if something is annoying and those people on your team, it's usually going to start with the physical therapist. If they do a couple, 3 months of good therapy and rehabilitative effort, and they're working out the kinks with myofascial release, where things are getting stuck, or stretch therapy, and they're working on movement, and they're noticing there's dysfunctional movement patterns, then and they're not correcting, right? Then probably the next referral is to somebody like myself who can do C3 level of diagnostics of complex problem solving in the orthopedic system. So whether it's physical medicine and rehab physician, or a family medicine, sports medicine, or sometimes there's emergency medicine, sports medicine, trained physicians, osteopaths who get into this field. But that's another key member. So probably like the physician, the PT, the body worker, and the movement therapist, something like that, 3 or 4 people around them. And we're this year going to be introducing even functional medicine and even some like counseling and like social workers that work with like pain psychology, because some pain does get anchored into our central nervous systems as well. So depending on the situation, then the team, keeping the patient at the center, can decide, okay, we need to bring in even yet another referral source from the outside. And having those trusted people on your team already, when the patient comes in to see you, then it makes it much more easy and much more simple for the patient to then trust, right? Because they already trust you, Chris, when they're seeing you primarily. And you're saying, well, this seems like an SI instability. I think I want you to see someone like Tim or Brad. And then, oh, but we also need some myofascial release work done here. So I'm going to want you to see this person. And having those people in our cell phones, textable, right? Where we don't have to go through these multi-layered systems with faxes and 8-page medical records with notes that can hardly be read anymore. But just to like, hey, I got someone I'm sending your way, need some help with this. Could you take a look at that? And I'm stuck. And just owning the fact that we all are limited, we all look at the patient from our own perspectives, and we all have really great strengths in a certain area or two, or maybe 3 if we're really gifted. But then, when when we know that what they need is something beyond what we have to provide, just being honest enough to admit that, being humble enough to accept that that's real, and then getting those people on the team. So usually when I'm bringing somebody back who I feel like has a lot of injury, I at least have a PT in the beginning phase. And then as they begin to mature through the 6 to 12 weeks of their rehab, then either into movement therapy, Pilates, or maybe into personal training and kind of more strengthening for return to sport, that sort of thing is kind of usually what I do. And if I find that when I see them at the 6 or the 12-week mark after their procedures, if they're really just, the strength is there, but they're really restricted still, right? Then if I have somebody who I can send them to who does more body work, that's really key.
Yeah, doesn't it come down to, do we need to, if we want to talk about fascia, right? The most prevalent tissue in the body, the connective tissue system, connecting everything to everything essentially,
Right.
either needs to be, let's simplify it, either it needs to be tightened or it needs to
Yep.
be loosened, right?
Right.
To look at that, it's like, just to simplify it to that, often it comes down to that, to helping people. And so what are those two options like? So to
Yeah.
tighten, what do we do? And to loosen it, what do we do? You
Yeah.
know,
It's a great point.
physical therapy, to tighten it, we think of strengthening, and to loosen it, we think of stretching, just to put it in a simplified manner. For the physician, your approach specifically, what do you do to tighten? What do you do to loosen?
Hmm. Yeah, that's such a great question because that's really the question that we are as physicians asking ourselves all the time. And a lot of the times I'm depending on my referral source to help me with that, right? Because if they've seen the patient already for 3 or 6 months and they're noticing like, hey, I'm doing this release work and they fall apart and they lose all their structural integrity and strength. So that's not working, but it seemed really tight. Or if they're, strengthening them, and they just can't get the power to come into their glutes or to their lumbar multifidus or what have you, their, hamstring. Well, there's probably something broken in the system, right? So in the physician world, the way I'm looking at that is it could be regionally that, like on the left hip, you could be broken down and needing reintegration and like strengthening and being put back together and tightening because of SI instability and glute tearing, let's say, and a hamstring tear. And on the opposite hip, it's very tight, right? And you know about this. Like you have regional areas that are tight and regional areas that are relatively loose. And that tightness is likely because the body has adapted, right? And so much more of the load is going through the healthy side that isn't broken down. And now it's become hypertonic and it's become too tight. So if all we do is focus on the tight thing, we're kind of like punishing the hero in the story if like that's the overcomer that's adapted to take the load, and the other side which can't do its fair share. Like if you think of, I like to use the analogy of an offensive line, and if you have three of your offensive line blocking well and one does not, that quarterback is getting sacked. And
Mhm.
so in order to prevent that, either the running back or one of the other offensive linemen has to then kind of like do a little alteration, which isn't as healthy or as functional, but they're trying to get the job done of helping that offense to move, but they're overcoming for a weakness that's on the team. And so sometimes tight is really heroic for an area that's weak and broken down and isn't pulling its own load. So what do we do? If it's broken down, that's most important, I think, is for us to find what's broken down, because as regenerative physicians, that's our key job, is find where are the broken areas in this big myofascial ligamentous tendinous system, and then with an ultrasound be able to get whatever we need to get there, which is whether it's prolotherapy or PRP or a fat stem cell treatment, to stabilize and regrow tissue, literally like build new collagen in an area that's been broken down. It could be tendon, it could be ligament, it could be muscle, it could be fascia. Like fascial injuries respond to all of those things too. So that's tightening, that's putting back together that which is broken to restore stability and strength and function to a part of the body that isn't working. And then after that's come back, after 6 to 8 weeks, okay, where are we now? Is that opposite hip still really tight? And oftentimes, actually, it is, because it's been going on for 5 or 10 years. The body's adapted. There's been chronic tetany or hypertonic holding patterns. That fascia has become, it's got little myofibrils in it, right? It can get kind of stuck. It can lose some of its glide, and hyaluronic acid actually in the tissue can be lost in chronically tight tissues. So we can go and then hydrodissect. What does that mean? Well, with an ultrasound, we can see the muscle, we can see the fascia, we can see the nerves running through those fascial planes. And with a needle with fluid in a syringe, we can pry apart the fascial planes, freeing up either the fascia that's adherent one muscle to the other, and or a nerve that's kind of gliding through that fascial plane that's become restricted. And guess what goes with the nerves is the blood vessels and the lymphatics, right? So all of that is what we're really treating when we're loosening something up with hydrodissection. And then the next question becomes, do we need to add some hyaluronic acid to that so that it doesn't just get restuck again and fibrose back down and get readhered? And so those are the kind of questions we're asking when we're thinking of loosening things up and freeing things up.
So Prolo and PRP and these approaches, let's talk about, the tightening, I don't know what came first, right? I remember as a physical therapist, we heard about Prolo ages ago. I think it was just for tennis elbow when it came out, something like that, right? And then physicians were just shooting it everywhere. If it works here, maybe it's going to work other places. And then hydrodissection, I don't know if it came later, but obviously it's incredible we have these options now. Patients have these options now, whereas before was surgery. And now we can really avoid surgery. And so my question, I guess, is you've had these options out for a little bit. They're not new, right? And they're not that old. But I mean, give us a little, I guess, a little timeline about it's been out for a while, but the difference is the training is now even more specific. I think what you're talking about with your collaboration is you've achieved more accuracy with ultrasound guidance and other things, just making it more specific and more accurate in your physical diagnosis as well as everything else. Would that be true compared to, I guess it's like people have lots of choices out there. Why should they see you and people like you and people who get trained at C3? Are they going to get better faster? Are they going to get, I guess that in a nutshell is, will they get better more completely better if they've hit plateaus or not getting better, or it's even faster, it's even more accurate?
Yeah. Wow. Well, we've only done the C3 conference once, and I think at that conference we had something like 7 physician attendees, right? We had mostly physical therapists, and we had a good smattering of body workers and movement therapists. And so we're hoping that we do broaden our reach to more physicians. And because we have some excellent physicians that do teach other physicians how to do regenerative treatments and the like, and now that we have more of a base of support as C3, our first conference was overwhelmingly successful, right? And so I think there's a bit more of a buzz in the community about what we're doing. I hope is that, yes, eventually we can say that when people see a physician or another provider from a C3 trained course, that they can diagnose more accurately sooner. I think that for sure. And then whether they'll get all the way better is always a hard thing to say, but I think that they will get better more completely. I think that's pretty true because we're looking at the much bigger picture. Like we take a lot more time with our patients. An example would be an initial evaluation for me is a 90-minute visit, and then a follow-up is 45. And I think in traditional orthopedics nowadays, your initial visits, maybe 15 or 20 minutes with the provider, and maybe it's the PA. And then your follow-ups are, perhaps 10 minutes, maybe 15 if you're lucky. And so when we're looking at traditional orthopedics, and I worked in an orthopedic surgical practice for 8 years before I branched out and started my own practice in 2018. So I have some experience in that situation, and it was great. I mean, we had spine surgeon, foot and ankle, hand, shoulder, sports medicine, joint replacement. We had it all. And so they've really shaped my understanding, and I think much more orthopedically than I did before, even as a family medicine, sports medicine physician. So I'm very grateful for that experience. But I did kind of wear out my welcome with them, if you will. And I think it had to do with the ability to get my patients better without surgery, started wearing thin for them because they admitted to me, like, this is a surgical practice. This is what we do. And it's nice that you can tinker and do these things. And in my mind, I was like, man, this isn't tinkering. Like, this is kind of, we're offering non-surgical treatments that prevent the need for surgery, that lower the cost of healthcare, that get people back to their health sooner without the trauma of surgery and any of the risk that goes with that. And so I was very excited. I thought I was improving their practice. And some of them thought that, and others were not thinking that way. And so I think that kind of encouraged me, okay, it's time to move on. But I do think of this as kind of like orthopedics 2.0 or 3.0, like our diagnostic ability has improved so much now with people like Brad Fullerton and Diane Lee and Phil Steele. We're all influencing each other and learning from one another and shaping each other's practices. And that's really what C3 is the ability for us to be influenced by others that maybe don't see it exactly the way we see it, but it informs our ability to diagnose and treat. So I know way more now. Like, my practice before our May 2024 conference, I rarely would treat a multifidus tear or intentionally treat it or knowingly go after it because I didn't know how to assess the multifidus. But thanks to Diane Lee and Don Sandel Cheedy and Phil Steele, they put together a couple of talks where I really knew how to assess the function of the multifidus. I knew its anatomic structure exactly and how to find that on ultrasound. And then it was a small step to then move on to, excuse me for a second. Mm-hmm. It was a small step for me to move on to treating that. And so since May, my practice has changed. And it's because of C3, but it wasn't my own lecture. It was the others that came. So I just want to make that point that we're all shaping one another. And I think we do increase our capacity to more completely treat our patients. Now, one other thing I'll say, in traditional orthopedic surgical practices right now, many times what's being treated is like the secondary or the tertiary problem in a chain that started in a root cause up here. And that's what we are getting to as well. We're like, and I think that's why we get more complete resolution, because if I used to treat, just like an orthopedic surgeon, just the tendon that was injured. That's how I was trained. I was trained mostly by orthopedic surgeons, and my mentors were trained by them as well. And so it was natural that we would focus on the tendon that hurt. But now when I find a lateral epicondylitis, I'm immediately looking at the shoulder and like, what's wrong with the shoulder and or the neck and or the scapula that's driving so much load to go to this tendon on the elbow. And I'm surprised every time, but there's always something upstream. And so I'm no longer really am I surprised. Now it's just kind of normal. And so then we're hydrodissecting nerves in the neck, and we're maybe stabilizing some scapular stabilizer injuries that Brad has taught us about and that we'll teach at this upcoming conference. So I think we are getting a lot more complete, and we're probably getting then a bit better outcomes because of that too.
So exciting. So you alluded to what we're going to feature at the next summit. Could you get into that? I think people can't wait. I certainly can't wait for the next summit. It was such an amazing experience to be at the very first summit that was launched last year, focused on the low back and pelvis. And so can you give us the dates, if you know the dates, and let us know what, sort of the headliners. What are we doing next year, and why should anyone come? What are we talking about? Is it interesting?
So, why should we come? So the C3 annual summit for 2025 is June 27th to the 29th. That's a 3-day course. And we will have an we're hoping, optional cadaver course on the 30th. So we're working on that. It's not a done deal, but we're hopeful that we can get that done. And it's in Denver, in Centennial. So it's not a far trip from the airport, pretty easy to get there. And it's the same location we had it last year. So that'll be great. As you referenced, our first conference, because it started about the SI ligamentous laxity, we started in the lumbopelvic region, and we really did a nice and thorough job down there. So this year we're moving up to the neck, the thoracic spine, and the shoulder. So cervicothoracic and scapulothoracic, and is it the shoulder? Is it the neck? These are some of the questions that we're going to be asking. And then we'll get different points of view on how to assess that. So we'll have Diane Lee looking at thoracic ring structure. We'll have Dawn Sandalchidi looking at diaphragm and how that correlates to the upper transverse abdominis and can even relate to pelvic floor function and shoulder function. And then we'll have Phil Steele, who's the master of the posterior suboccipital neck, where there's 4 layers of muscles in the suboccipital musculature that all meet together at the nuchal raphe, which is like what we used to call the nuchal ligament down the midline along the back of the spinous processes. He'll be taking us through that. We're going to look at the brachial plexus, how all those nerves that we know about that control scapula and shoulder and arm are very knowable and accessible with the use of ultrasound, and we can hydrodissect those nerves if they're compressed and not functioning well without the need for thoracic outlet surgery. So if you see thoracic outlet patients or cervical instability patients, then you're going to want to see Phil Steele talk about those things. We're going to go into the scapula, and when we see those scapular dyskinesias or they're malpositioned, what could be the causes? Is it neuromotor? Is it soft tissue breakdown? Is it fascia? Is it muscle? What's going on there? Is it that the fascia is too stuck and it cannot glide on the rib cage? And Brad Fullerton's going to take us through some great anatomy to look at that. So we're going to go far and wide into the structure and the anatomy. I'll be looking at some shoulder cases. I'm going to be presenting the case of a competitive weightlifter, female athlete of mine, who had very simple rotator cuff injury. And over the course of time, we realized it was so much more than just rotator cuff injury, like we talked about. There was root cause that went all the way back to SI instability that was driving rotator cuff pathology. So if that doesn't tweak your brain a little bit, then I don't know what will. So we're gonna go through that kind of a case. And then this year we're gonna throw in some other additional features that are different. Like we're gonna have a speaker on compassion. So our ability to have compassion for others, which is what drives our practices, is best determined by our ability to have compassion for ourselves. And so we're going to look into that as healthcare providers. Do we do that? How well do we do that? How are we doing? And then we're gonna get a visitor, a functional medicine expert, Dr. Jill Carnahan, who's just a huge leader, but with a heart bigger than her following on YouTube. And so I think she's going to be a joy to have with us. And I'm seeing if I can get a central nervous system pain psychologist to help us with those kinds of central sensitization, if you will, types of chronic pain. They have some great research that's been done out of CU here in Boulder a couple of years ago. So it's quite a splattering of things. We're going to have Gil Headley taking us through some anatomy with his wonderful anatomic detail. We've got workshops with ultrasound and physical examination techniques. It's going to be far reaching. In 3 days, we cover a lot of ground. So it's a lot to get to. And last year was the best conference I've ever been to, and I'm 58. I've been to a lot of medical conferences, and we nerded out on the science for sure. But I think that the thing that was even more of a highlight for most of us was the spirit in the room. And so I think you don't want to miss it. I think being there in person, feeling the hearts, the amount of care and love that people have for their patients, for the field, and for one another is just inspiring.
Well, you are inspiring, Tim, with your vision come true. And we're all looking forward to the next summit. My wife and I will be there working with shoulder dyskinesia and getting some good exercises, some ways to feel the proprioception. That's one of the most challenging things, to get those scapula behaving right after even they've had good rehab medicine. It's like we got to get it functioning right. And Ann and I will be doing that. So we're so excited to join you guys we'll be on day 3. So anyway, if I could encourage everyone from MDs to PTs to allied healthcare professionals and movement professionals, We're all going to get together. We're all going to be collaborating because it's called the Collaborative Care Collective. And we look forward to inviting you to come join us to have a really good time learning and really just working with like-minded and like-spirited people. Anything else, Tim, that you want to say?
No, I think that's so great. And yeah, I look so forward to seeing what you and your lovely wife have to teach us. One of the things you asked me earlier was about, if we had any comparative cases of a patient who maybe had had surgery and then had some treatment with us. And I wanted just to highlight one that I was thinking about.
Sure.
She's a lovely gal. She wants to come to our conference and us to like present her, but I think she doesn't quite exactly fit what we're shooting for in this conference. But she was a shoulder patient, and her right shoulder, she'd had a subacromial decompression with a biceps tenodesis for kind of standard bicipital tendonitis and impingement-like symptoms. And so, unfortunately, she didn't have a good response. She had persistent pain in the shoulder, and that surgery, the subacromial decompression, is in the orthopedic literature is about 30% effective. And I think it's partly because the concept is somewhat limited and flawed and just not always accurate, right? That you have to remove bone to make room for tendons to glide underneath the acromion. In fact, in most of those cases, I'm seeing partial tendon tears, tendinosis of the supraspinatus and the subscapularis with little tiny partial tears on ultrasound, easily treated with a little needle injection of Prolo or PRP. And then you can put a little of that same stuff into the arthritic AC joint and the glenohumeral joint, right? So it's pretty straightforward for us to treat that. And it takes the patient maybe 2 or 3 months, and they've kind of turned the corner. They rehab with someone like yourself, and then they're on their way. And that's what we did on her left shoulder. And it took her about 3 months, and she was good to go. She was on her way. But unfortunately, with her right, she'd had that surgery done like 10 years before, and they did a scope. And unfortunately, she had, persistent worsening pain. She had really bad glenohumeral arthritis. My guess is because sometimes when they scope, if it gets a little too hot, it can be somewhat injurious to the cartilage, or if they're poking around in there and the needle or the scope injures the cartilage a little bit, that can happen. And so in any case, she got quite a bit of worsening of her arthritis. Her tendons never really got treated because they were tiny partial tears that the surgeons don't fix. They fix the ones where the tendons pulled off the bone and reattach it, and that's great. Need them, absolutely. Broken bones in multiple places absolutely need surgery, right? But if it's just an interstitial tear, that's not something for them. And with an ultrasound, we can just put a 1 cc of Prolo or PRP in there. And so we got her tendons better, we got her joint feeling better, but it took us like a year and a half or two on her right shoulder to get that to kind of where it was almost as good as the left one that never had surgery. So I think that's just a good example of comparison of the surgical shoulder versus the non-surgical shoulder. And so you don't know what you don't know. And she didn't understand she had an option at that time in her life to do regenerative treatments. And who knows, even back then, maybe I wouldn't have been good enough to have got her where she would have been ultimately now anyways. So, it's not to say that surgery is bad. Surgery certainly has its place. And I worked for 8 years in that field, and it worked really well for most people. And there was many times though where there was a lot of things I could do to help even after the surgery to make their recovery even better. And I think that's the thing, like that was collaborative care within our own office. And I loved it. And so it's best when we have a team that includes an orthopedic surgeon too, right? So it's just a little hard for them to show up at these conferences because they're really busy taking so much care with, making sure their surgeries, they're doing those right. But yeah, that's an example of a surgical shoulder versus a non using regenerative treatment.
Well, I think all the practice-based evidence, I'll call it, that everyone who's coming to the conference, the presenters come with, it brings hope. I think the one word is hope to practitioners and their patients that there are solutions, other solutions that perhaps were not discovered or were not offered to them. And so I encourage anyone who's interested, if any of this resonates, I would go to collaborativecarecollective.com. Check us out and register for the summit. We'd love to see you there. On that note, we'll end this interview. So great to have you, Tim. Thank you so much for just creating this wonderful collaboration with people who really care. We're all going to get together one more time next year.
Yeah, thanks so much for joining us, Chris. I mean, I really do appreciate having you on the team and all the others. I mean, it really is, it's a dream come true, and aptly, it couldn't have happened unless these other people like yourself were willing to put themselves into it, and that's what I love about it. There's a huge generosity of spirit, I think, in the crew that we've assembled, and that really just permeates and comes through. So if you're looking for a tribe that's bringing the passion and the love and the hope, yeah, I agree with Chris. Come join us.
Fantastic. Thanks so much.
All right. Thanks, my
Next.
brother.